name is Lauren. I am a home infusion nurse, and I see mostly children. I have a background in pediatric care. I've worked at Children's Healthcare of Atlanta for 17 years in the ICU. So I've been doing home infusion for about 3 years now. And this has just been an eye-opening experience to see a different side of nursing. And I'm just so indebted to all of your lives and the experiences that you share, and really how that has impacted my life, and not only my personal life, but also my career as a nurse. So I really owe you a big thanks for all of your hard work and your dedication to your diagnosis and getting better and the treatments that you have gone through.
I'm Dr. McLaughlin. So I'm one of the new attending doctors at CHOA, Children's Healthcare of Atlanta, for pediatric neuroimmunology. So one of passions of mine is in particular trying to work on building a program for transition of care for pediatric to adult. So a lot of our kids are diagnosed with MS, but also MOG antibody disorder, NMO. And so that's a program we're trying to build out. And I'm just so glad to be here today to hear you guys' stories and talk through what we've learned, what we're learning from you guys.
Hi, I'm Diana Vargas, and I'm an adult neuroimmunologist at Emory. And I've been working with neuroimmunology patients for 15 years or so. And it's, one of the things that we see a lot is that transition of those kids that are diagnosed, and they're at that age gap where they have to leave their pediatric neurologist and kind of see another physician, establish care with somebody, trust somebody else. So it's a big deal for patients. And it's also, for us, it's very important that, as a team, we're able to make that transition the best possible. So, we work together very closely every time that we have somebody who's coming in and transitioning care, that there are no gaps, that the information is available, that the management continues, and sort of relay the information from, the aspect of reaching adulthood and what that takes. And so, yeah.
Great. I'm going to first start with Lauren. Could you please touch upon what are different ways that patients could receive their treatments? You talked about some of the work that you've done in your different careers. So tell us how people can get their treatments.
There's the traditional, if you're receiving IV infusions, traditional IV infusion suite, either attached to a hospital or a local infusion center. And that is a pretty typical course of action where when you first start receiving treatments, to go to those infusion centers. And then there's also home infusion, and that is what I do. The company that I work for Solio Health. It's a specialty pharmacy, and we do have an infusion suite. And so there are some patients that do require their infusions to be done in an infusion suite. And so occasionally I will go to the suite and see patients there, but I majority see patients in their homes. That has been so life-changing for so many patients. And unfortunately, a lot of people, physicians and patients alike, are not aware that that's a possibility or an option for them. So if you are receiving infusions at an infusion center, I would definitely look into the possibility of receiving your treatments at home.
Great, thank you so much. Also, full disclaimer, we have no connections to Solio. There are multiple home infusion companies we work with, just so that everyone's aware. Okay, Dr. McLaughlin, can you talk about what are some things that would be helpful? And actually both Dr. McLaughlin and Dr. Vargas can talk about this. Dr. Vargas touched upon this. When a child is transitioning from pediatric to adult care, what is important for them to know? Or even when you're transitioning from one doctor to a different doctor, what do people need to know? What's important? What do they need to do when they bring it, all the information to their next doctor?
Yes, that's a good question. So I think one of the important things is starting early, just to try to talk to the patient themselves about their diagnosis. Obviously it always depends on what their age is and what their understanding is, but at each appointment, trying to see what their understanding is about their medicine. They don't have to understand everything about all the mechanisms of it, but if they can just give a name to it and kind of understand the importance of it, then it kind of empowers them. So something that we have done at CHOA, and in particular in the neurology clinic, is gotten one of our senior nurses is involved in a transition of care program for kind of all the neurology patients to start early with these discussions of transition of care readiness is what we call it. But it's talking through kind of just asking the patient themselves, like what they understand about their diagnosis so that they can feel empowered. And then another piece is that we just have, we have a nurse care coordinator that helps kind of, it's really a full-time job that doing all of this insurance piece, but she comes into a lot of our patient appointments just to check in. And she is like so powerful to kind of feel out like how the patient is doing and what's going on socially and emotionally. And so that's just been a super important part of their care journey. But just starting as early as possible is, I think, what's really important.
So, I feel like it's a process, and understanding, where the patient is in their age is very important, right? Because you're not kind of, the way I see things is you're not really built to understand and be able to, as a teenager starting early adulthood, to know you have a chronic disease and that you have to take care of your health and that it's not your parents' job anymore as you start growing, and understanding that there are things you have to think about, not just school, not just, life, in your late teens and early 20s. So, the way when we receive a pediatric who's graduating into adult neurology, I see it as a process where the first thing is there's usually always prior communications. We already know this patient was being seen, at CHOA, and they're on medication. For me, the first priority is making sure there's no gaps, making sure that there's no delay, that there's no, I can't get my medication because we have this change in physician. And so that's the most important thing. We make sure that, there is continuity of care. The second thing is to establish that level of comfort, that connection, and so usually a patient will come with their parent, with, the person who's been taking care of them for the entirety of their diagnoses. And, getting them in the frame of, you have to start taking charge of your health, because eventually it's not going to be that parent there anymore, right? That's one big step that, kids, as they're growing, and, they have to start identifying that they have that responsibility. So as the years progress, that you start seeing them, that maybe they might not be as interested in the clinic and interaction, and it's more the parent. So emphasizing that communication with the patient is very important, because then they start understanding that they are at this point the ones that have to take charge. And so that's a very big step. The other thing is, a lot of the medications that are used in the pediatric population might change when you become an adult. And so a lot of the medications that are FDA approved, the newer drugs, maybe these are medications that, are possibly better, and so the possibility of switching medications, increasing dosage of medications, is also another big conversation to have. So it's a series of things that are done in multiple appointments. So oftentimes the first appointment is making sure that there are no gaps in their treatment, and establishing that, getting to know them getting to know me. And then we do kind of those follow-up appointments that are particularly to educate on, these are our options at this point. These are, what would you prefer? So we like to give you the option, okay, a lot of times, because, infusions, oral medications, injections, these are not just like, hey, take this and that's the only option we have, right? So we have a lot of a conversation about the different options. What does that mean? When you're in your early 20s, you have to think about the rest of your life. And so we think about, okay, what are the consequences of certain medications for a long time? And so a lot of communication, and then there are changes, but the key thing about everything is there being that bridge, so that patients don't feel like they don't know what to do, who to see, and then not being able to continue to take the medications that they're taking that has been working for them.
Great. And then here is literally the $1,000,000 question. What are some tips and tricks you have? What are prior authorizations? What do appeals look like? How does that process look like? And then this is for all three of our panelists here.
Well, so yeah. So, the first thing that I would say is that, if life were perfect, we wouldn't have insurance companies, because it really is a struggle, and the first thing the conversation I have with my patients is, look, yes, we order the medication, but the more proactive we work together, the better the chance we have of getting that medication approved. So I bug from one end and you bug from the other, but we both have to bug together. Otherwise, things will just sit endlessly and there you are not having a medication. So the first thing is being aware that these, the insurance unfortunately is, nobody can afford these medications. We have to be able to have the insurance pay for these. So we have to establish ways of doing things. There are many different things that happen, but I think bottom line is a lot of it is, when you get to know the system over time, and there are medications which may know that are not going to be approved if you do something before, right? Ultimately, I hear a lot of times first from my patients rather than the infusion company or the clinic staff that their medication was denied. So I always tell patients, if you get that letter before me, let me know right away, because otherwise, the more the time that goes on, the harder, the more things are delayed. The documentation is key. So we know what we need to put in those notes in order to get things approved. And eventually, the peer-to-peer ends up being the bottom line. And the way that I've come to do things is slightly a little aggressive. I try to cast my inner demon, and I'm prepared for battle anytime I'm on the phone. Little tricks I always use for me, I always ask for whoever I'm talking's name. And I tell them, I'm going to document that I spoke to you and that you either approved or denied this medication. And that tends to put everybody on alert, because anytime that you are, and the way that I frame things, when I'm kind of like, when things, they're giving me the runaround, the way I basically say, you are involved as well as me in the care of this person. So if you are denying a medication, you are at fault, just like I am at fault over doing something if I don't do it for this person. So I need your name. And that usually works. Like that will put them usually on. But it's a battle. There are a lot of paperwork and things around it. But I feel like the most important takeaway message that I would say is you have to work with your doctor. You have to be proactive. Don't expect that because you got that letter of denial, that we got that letter of denial right away. It might be sitting in somebody's fax machine, right? So if you can maybe spend some time on the phone, just like we are, that is going to be more effective. So think of things as a team working together to get things done. Don't just expect that they'll handle it, because a lot of times it's very hard and you're advocating for yourself, and it really helps us, when we know things and we can kind of work together.
That's really helpful. I will just speak from on the pediatric side in my experience with appeals and peer-to-peer. So if as a patient you are so fortunate to not know much about like what the terms mean and everything, essentially there's just two different kinds of processes for trying to get a medication that was denied. And the truth is a lot of it goes through automated, like everything's automated in healthcare with insurance. So a lot of times it's just about a diagnosis code. So a peer-to-peer is supposed to be theoretically the fastest way to get an appeal process done, because it's supposed to be that the insurance company has someone available who has the same, like, has medical training and expertise in that area, and they talk to the physician, and then it's like one phone call that gets scheduled, and then at the end of the phone call, there's a yes or a no. In my experience, a lot of times the phone call doesn't happen because it's scheduled and they just don't actually call you. And in reality, also, a lot of the times, almost never the person who works at the insurance company has expertise in that area. Like, they're not pediatric neuroimmunologists. They're not, that's just not their training. Sometimes they're pharmacists. They have all kinds of different kinds of training, but it's just not in these specific diseases. And then the appeal process is, theoretically supposed to be longer. It can take up to like 30 days before an approval, and it involves all these letters that have like a deadline. What you really need to know as a patient, as like Dr. Vargas said, is just being proactive. And like she said, you might get the letter because, unfortunately, in this country, all the insurance companies work a little bit differently, the way they send things, the way they process things. So just being proactive and being willing to like reach out to knowing the person in your doctor's office who you can reach out to for these things. In our office, we're very lucky to have Gwen Carr, who is our nurse case manager. And I'll just put a plug in for how great she's been for getting our patients access. So she has a role where she works very hard to get patients infusions lined up, and she works with their insurance companies, and she figures out the fastest way. So she tries the peer-to-peer and the appeal, or tells us which one we're supposed to pursue. And I just did a preliminary research project when I was in my fellow year, where we basically just looked at how effective it was to have Gwen in this role as a specifically assigned to do these things. And she actually cut down the time to starting treatment for our patients. This is specifically for MS patients, but it's just as a case example, from like by 2 to 4 times. So like the average wait time before her was like 4 to 8 months to getting started on their first infusion. And then it went down to like 1 to 2 months just with her. So having someone like that is very helpful.
To piggyback off of that, I would say, like, for the physicians, it's important for that physician to work with whoever that nurse coordinator is in the office to find out which specialty pharmacy has been the most responsive to these appeal letters and takes more responsibility from that. And I'm not speaking from a perspective from Solio. From a parent perspective, I have a child that's on a specialty drug, and my insurance, without me knowing, went through a different specialty pharmacy, and the drug was denied, and I was never informed. The doctor's office was never informed. I found out by just, nagging and nagging and nagging. And then from the perspective of the pharmacy that I work for, we are much more proactive in seeking out those appeals, and often find out that the drug was denied prior to even, the physician's office finding out. So developing that relationship is really important for the physician and the nurse coordinator to find out which specialty pharmacy is very successful with getting drugs approved, and what are those trigger words. Sometimes the specialty pharmacy will know what trigger words need to be in those appeal letters, or the physicians need to use in their peer-to-peers to make that approval happen. Documentation is also super important. Whether that is maintaining your appointments with your doctor's offices. I can't tell you how often, unfortunately, and very fortunately, I see mostly children, and the neurology office is amazing with staying on top of all of, the authorizations and the recertification periods. But recertification is generally an easier process because it's filed through as like a continuation of treatment versus a new therapy. And you can prove with a nurse's documentation and the physician notes that therapy is improving, and you can show percentages and like what functions were at baseline prior to starting treatment, and then where that patient is at this point. So that is all very important. But if you're not maintaining your doctor's appointments and going to get that documentation done, that's going to be a stop for that recertification, or that initial certification. So it's often the insurance company requires clinical notes every so often, and if we don't have them to submit, then there's nothing that we can do from a specialty pharmacy perspective to get that drug approved. So that would be a really important thing. And then there's been a lot of talk today about advocacy groups and peer support groups. dig into those networks and find out, where have you been, where have people in your area been successful, and how, what was a trick that you were able to use to get your drug approved.
Just one quick thing, a couple of two things. One, first of all, when you're using your parents' insurance, for example, and as you're getting older and you have to either get insurance on your own, and so this is a big switch. And so one very important key thing is, when considering that change in insurance, you can actually look at the plan. You can look at what is the coverage for these drugs. If you don't understand it, ask your doctor, ask the doctor, because if you're choosing, it's going to be a big deal that if you have the option to choose appropriately, so that you don't have that situations where the medication that you were on suddenly is not approved and you have to go through loops to get it approved. So that's one thing. The second thing is, it's actually very common, the fact that your drug will get renewed automatically. Usually it's every year. Sometimes the insurance will give you kind of that 6 month of extra time for you to see that appointment, so that they can get those notes, so that they can continue to give the medication. So it's very common that we get patients calling back, and in the infusion company sending us message saying, we cannot continue to give this medication because they haven't seen you yet, and they have an appointment for next week, and the insurance is not going to approve it. So always look at those, those letters that give you your drug is approved from this time to this time. Make sure that you have that appointment before, that medication is about to expire. Otherwise, there you're running to try to get in, we're running to try to get you in, probably on a full schedule, to try to have no interruption of care. So just looking at it and knowing that it might be maybe once a year that you're seeing your neurologist. If you haven't seen them for a while, again, think of that, because that's a big issue.
Great. Any questions from people who are here?
I would just like to suggest that there's an overlap between respirologists and infusion nurses or practitioners. I had COPD, so I had polycythemia vera, which has to be treated in effect by an infusion nurse. But it's the reverse process. So it's not just your specialty, it's every specialty, and you have to get an approval from a specialist.
Yes. So, it's much harder for you to get the drug approved if you're, if it's your general practitioner, or if it's a general neurologist. Oftentimes it will actually be required in the insurance that you have that the subspecialist is the person who can provide the order for the infusion. And so it's important to more so if it's a rare illness, okay, more so if it's a medication if it's a rare illness that does not have FDA approval, and you're using drugs like in MOG, for example, knowing these things are very difficult, because as a patient, you're not really supposed to know these things. But a lot of times you lose a lot of time, and it's all because the person who's prescribing the medication is not accustomed to using these medications, or might not have the specialty or the subspecialty to have the approval. So always try to connect yourself with the most specialized person in the disease that you have, because they're going to know the most and make the process easier.
Hi there. I am going to ask the real hard question, and it's going to suck. Managing copays is hard, and I'm in a kind of a bad situation. I can't really afford my treatment, even though the drug is free. It's like the drug's free, but the infusion is still way too much money. And my doctor is not willing to do like an outpatient facility or anything like that, or do like at home. I know that those ones are usually a little cheaper. I'm seeing a doctor at Mayo. So they only write for Mayo, and I'm kind of just in this bad situation. And every infusion seems like it's going to be costing me about $5,000.
Yeah, so these infusions are unaffordable, and we it's important. I feel like as being on the other side, it's the type of conversation that a lot of times as a patient you feel it very hard to talk about with your doctor, right? Like, yes, I'm giving you this drug, but you're having issues affording it, and it can be kind of like that, breaking that ice of talking to your doctor. The reality of it is very important, because there are options. In most of these diseases, you have options. And so if home infusion companies are, yes, they're a lot more cheaper, and oftentimes the insurance will make you go and use a home infusion company. And there are a lot of times they're more convenient. You can actually even have, Solio, for example. I also don't work with Solio. I work with Solio, but I don't have anything. But, they will go to your hotel room if you are somewhere in another city traveling, and they'll give you the infusion right in your hotel room. So they're very convenient in that way, and they are cheaper. The first thing I particularly do, we have a pharmacist that works with us. And when I'm trying to decide on a drug, our pharmacist will actually have a visit, a telemedicine visit with the patient, and they'll discuss. When I'm thinking about a medication, I usually give 3 options. And these are like the 3 options that whichever one you choose, I'm okay with. They're kind of like in the category of effectiveness. So I would say these 3 medications, for example, I'm talking more of MS, usually with MOG, and NMO also has, we have other drugs we're using as well. But if there other options that are equally effective to treat this disease, I tell you about them. And I'm like, you're going to learn more about them with our pharmacist. And the key thing that she does is she looks into your insurance, and she'll look into the copays, and you might really want or really like X drug, but that X drug will cost you much more of copay than if you use drug B. And so having those options laid out to you, if they are a possibility, is going to help you decide, because you already know that either one of these 3 will work as well. But maybe you're afraid of needles, or maybe, you don't want an infusion, or maybe, you forget to take your pills, and you might want to make that, even if you're scared of needles, you're like, you know what, I'll go ahead with the needles because it does not cost me $5,000 to do that infusion, right? So that's one thing. And the second thing is you have to sit down with your doctor and say, I can't afford this. So either I find options to be able to get it, whether it's, using and at least knowing what the cost is in using a home infusion company, or you're not going to afford your medication and you can't take it. So I feel that communication is very important, because that's one option. The other thing is that there are also, advocacy groups and, and societies that will help as well, when copays are really high. But I think the most important thing is to have that conversation with your physician and have it be very clear that you can't afford the medication, because we do have cheaper options.
Really quickly, just to close out the session, just to add on to that, certain hospitals do have patient assistant programs that will help provide infusion services for free. For example, I've worked at certain institutions that do offer that. So that'd be something that you can look into. The other thing, all of the physicians, all the people that you see, they are doing their best. But sometimes I feel like if you feel like you're not being heard, it might be worth seeking another opinion. And I'm always been open with my patients and families that they want to talk to somebody else. I'm always open to that, and we can collaborate together. So that's another thing to think about. Anyways, thank you so much to our panelists.